I'm Peggy O'Kane, president of NCQA. I founded NCQA 35 years ago. We've made a lot of progress, but as I prepare to leave NCQA, I feel there's unfinished business. That's where this podcast series comes in. I'll be talking with some of healthcare's brightest thinkers, executives, researchers, and innovators working for real change. These conversations are for people who are curious and want to help the U.S. escape bad health outcomes and runaway costs. This is Quality Talks. Today, I'm excited to have Marc Overhage join the podcast. I've known Marc for years. He has been tirelessly trying to bring the future into healthcare. He helps us get enthusiastic, and he's also practical and thinks about the nuts and bolts of how do we bring about the change we want to see. I'm going to ask Marc to introduce himself because he has quite an illustrious resume. So go ahead, Marc.
Well, it's always great to be able to talk with you, Peggy, and the leadership that you and NCQA have been so instrumental in bringing the future to healthcare. Just always takes longer than we think. I've spent a lot of years as a primary care provider, about 20 years at an academic medical center. My research was always been in healthcare IT, data integration, data quality, clinical decision support, and all of that about how do we make care for patients better. I spent around a decade with electronic health record vendors, which was fantastic to understand how and why things were hard or easy for them to do and what the motivations are, because a lot of the challenges we have in healthcare are getting motivations aligned. Everybody wants care to be better, but we've got to get a layer below that of getting practical and pragmatic. And then spent 6 years at Elevance Health, a large payer, and that brought a nice perspective, understanding the focus organizations like that have on wanting to see care better, but having to align incentives. That's a critical part that quality measurement has played, is in helping organizations align their investments behind important improvements. So I've had the chance to see the healthcare ecosystem from many perspectives, but they're common threads. And I think that's some of the things we're going to talk about today, which will be fun.
Yeah, I agree with everything you said. What feels like such a shame is there are so many good people in healthcare who came into it for the right reasons, who have the best intentions, who are smart, who are driven, and yet the system thwarts all that energy so many ways. We've been talking about how fragmented healthcare is. When NCQA started, I would say it was less fragmented, or transactional, I think is the word that you use. So why don't you talk about that a little bit? And why is that a problem? Why could it be a problem? And how do we go about making it not a problem?
I'm a primary care provider. My wife is a primary care provider. My daughter is a primary care provider. So I'm come with that bias of integrated holistic patient care. We need to understand the patient as a person, their motivations, their goals, what's going to help make them healthier. All things that we think about and learn as primary care providers and clinicians dealing with patients. But the second layer is that holistic view of how the patient's care is being organized and prioritized. Is it the cardiologist managing their cholesterol, or is it the primary care doc? Who should the patient call when they've got hip pain after radiation therapy for their cancer? The oncologist, the physical therapist, that coordination, making sure that the right providers are brought into the team. As you say, Peggy, everybody's trying to do a great job. We've tried to make care efficient. You get 15 minutes to see the patient in primary care, but it's a complex system. And when we push on the system in one place, we often end up bulging out in another. And it's hard to predict and understand. Many people would think healthcare is a complex, chaotic system. It's hard to predict, and we don't always appreciate the adverse effects of trying to do something good over here. The drive to efficiency and focus leads to dealing with the patient in transactions in little snippets, and very hard for any provider to articulate what is the patient's overall status, what is the overall plan, and the patient reflects that. They don't know who to talk to, and even intelligent, well-informed patients we see routinely struggling with how to access the system. And then the last bit of that is it's more challenging to focus on wellness, thinking about how do I maintain my health, not just fix things when it breaks. It's been difficult to fit into this transactional system where we're focused on, is that dollar we're spending getting value, and can we measure that value?
Right. 35 years ago, NCQA walked up to the system and poked it in the chest and said, "You're not doing a very good job, and we are here to help." And so we created our health plan accreditation. The beauty of health plans is they've got the whole ball of wax, especially if they are at risk, value based or HMO model. And so that has been where a lot of work has been done. Even today, though, you don't necessarily have alignment between the incentives of the health plan and the incentives of the delivery systems they're contracting with. So we've made progress in having some plans having large partnerships with providers. For example, United Healthcare now owns so many practices and is the largest employer of physicians, and these are primary care practices. But, and I'm not speaking about United in this instance, there's also friction because of the lack of alignment of the incentives. So the plan is at risk. And if you spend money in a poor way, the plan is eating that. But if you're a hospital system and your incentive is to drive the spend because that's your income, you get a lot of chafing and you get things we've seen with utilization management creating unhappiness across the system. So trying to get alignment of incentives feels foundational to me, but we feel as far away as ever from that. You kind of alluded to that in your first remarks.
No, absolutely. And I share your frustration at the challenges we have in getting these alignments. And of course, it's true in any industry.
Yeah.
The friction is an opportunity for revenue and to make additional money. And people did a wonderful job of taking advantage of that, whether that's the PBMs and the way that they have manipulated things, even TPAs, where you think that might be a fairly simple
Party
transactional.
administrators, right? Yeah.
Yes,
Yeah.
correct.
Yeah.
Organizations have taken advantage of the friction and the poor definition in our system. And you can't blame people for being entrepreneurial and trying to take
Yeah.
advantage. But at the same time, not for profit health systems, health plans, the large Medicare and Medicaid population that are publicly funded, we do have to worry about that extra costs that are incurred on top of the fact that healthcare is so complex and there's so many people involved and so many factors that the average person can't understand them. I find myself dealing with family illnesses, just processing the explanations of benefits and the claims and what's on the patient portal and trying to assemble that into understanding of the patient's care is really challenging, even when you know a lot.
Yeah, very true. So let's switch gears a little bit because 35 years ago, NCQA said, we have an idea. The employers were our partners in this. They were all on an HMO strategy. Sophisticated employers were on our board. They were Fortune 50 companies. The people themselves had black belts in total quality management, et cetera. So we were given an opportunity to try to do something. And one of the things that emerged was people said, well, if you don't have the data on your population, how are you going to manage them? So we set up rules in accreditation about knowing who your key populations are and how you're going to achieve the best outcomes for them. Part of that strategy was quality measurement. And while we've had good things emerge from quality measurement, we're at the same time seeing the limits of it and unintended consequences that are not good. Let me give examples. One is people teach to the test. So if your hemoglobin A1C is under control, you get points towards your stars and Medicare Advantage. That's a big market mover. If you don't have a colon cancer screening, you're going to be marked down. We see in a number of these areas, there has been steady improvement over time. That's great. But we're kind of stuck in the world of primary care, and we have questions about both the intersection of primary care with specialty care and with hospital care and so on. But also, there's a reason we're in the land of primary care. One is it's important. That's a good reason. But the other is the data aren't available in other areas. Or there's been resistance on the part of many sectors of healthcare in controlling their own quality agenda, not making anything public. But one of the more disappointing things is many physicians think of quality measurement as a pain point. They don't see the value. They feel like it's an additional burden to already overworked people. They also resent that they find out a year later that their number was maybe 40%. And how are they going to do anything about that now, et cetera? There's just so much to work with there. So much could be better. And we're trying to work on that. So maybe you could comment on that and some of the priorities.
So many good things to unpack there. Start with, as you say, I don't know that I ever met a clinician or a nurse practitioner who didn't want to do a good job. To your point, we've got an alignment of goals, but how we get there, we maybe have a challenge. And part of that is we started quality measurement with claims data because that's what we could do. There was nothing. And NCQA said, why do we have? What can we do? Well, claims will teach us. And it has taught us a tremendous amount. And we've made good strides. As electronic health records have become ubiquitous, data has become increasingly available. Not that it's nirvana and it's all perfect, but virtually everywhere there is digital data now, which we didn't have. A second thing, having a way to interact with the provider at the point of care is critical. And electronic health records, with all of their warts and problems, are one of the powerful vehicles for doing that. When I started training, I was fortunate to train at a place that was far down the road and was thinking it was a piece of paper that we got that said, here's a summary of the patient's data. Here are their diagnoses. Here are their past prescriptions. But also, it was literally called tidbits from the computer. Here are things that you might want to think about that you might not otherwise think about. Many of them topics that NCQA is focused on because there is consensus about them being good things to do, because they are measurable, because they have value to the patient. But it was hard. How do you deliver that piece of paper? And all kinds of things were tried, pagers and early handheld devices. But the fact that providers are sitting with the patient and a computer at the same time is a powerful tool. And if you go back to the early 2000s when meaningful use was being conceived of and built, one of the primary justifications for that investment was the clinical decision support, or bringing information feedback into the care process at the point of care. And one of my personal frustrations is today, we're not very far down the road in clinical decision support. Yes, drug interactions are getting checked for, et cetera. There are some, and it's like best practice alerts embedded in Epic, for example, and in other electronic health records that nudge in the direction. But compared to what some of the leaders at Vanderbilt and at Brigham and Women's and at Reagan Street Institute, where I worked, had done in the 80s and 90s, we have a tiny fraction of the opportunity being exploited. It really is a question of how do you build quality into the care process, not measure it in. We all know that measuring into a manufacturing or a creation process is a limited strategy. It only goes so far. And the Toyota production system, the Danaher business system, other very successful models are predicated on how do you build quality into the process as it's happening, have the ability to pull the chain and stop the production line if something isn't working, and to continuously improve it. How do you stop and say, okay, why are so many of our patients not being fully treated for their congestive heart failure? What is in the way? How do we improve it? I have a little bit of soapbox challenge, and the clinical decision support is a part of many of those challenges. There are others, including the challenge of how do you not overwhelm people with feedback when you only have 15 or 20 minutes with the patient? I can't deal with 25 suggestions or tidbits from the computer. And I think there's ways to approach that. So going back to your point about providers, providers want to do a better job. I think quality measurement has been frustrating for them because we have, number one, as you say, the retrospective process provided feedback in a delayed fashion, less so than near time in the process. And I think we have the tools and capabilities to do that now. And specialty for them, there is more nuance in appropriateness or safety or outcomes in specialty that historically we may not have had the data to deal with. For example, we didn't know what the patient's 6-minute walk test results were, or we didn't know about the results of their cardiac cath in a way that we could leverage. Today we do. And while I have huge enthusiasm for generative I think it's more limited than some people do. While we can definitely clean up and improve the data pathways, generative AI helps us understand even better than we could 2 years ago the content of the patient's record in nuanced areas. As a concrete example, in a cardiac cath, where the patient might get a stimulus, they might get a certain drug, or they might have two readings of their ejection fraction. And it's recorded in a column in a report. And it's been traditionally difficult to sort that out. But the tools today can sort that out pretty well. So our data for specialty has taken a quantum leap. And from CMS sort of models where, well, let's do unique codes in our billing and things like that, to today where the specialist is caring for the patient, the data are increasingly available. We're at a point where we can tackle more in the specialty domain. We also need to hold them to a standard that needs to be actually improving. We have examples of that. I just saw an article that myocardial infarction is no longer the leading cause of death. Since 1980, it's fallen by 66%, which may seem like a very long time. It is,
Well, that's pretty amazing.
but an
Pretty
amazing
amazing.
increase. Then, of course, the natural consequence, and this is the complex chaotic system problem, there's a lot more people with heart failure that need to be managed well. There's more people with arrhythmia because they have either survived their heart attack or they averted the heart attack, but their heart is still being damaged. And so we've changed the problem.
Yeah. Yeah, and that's going to be inevitable, isn't it? When I was a young respiratory therapist, a lot of the patients in the hospital were congestive heart failure patients. And I just had the opportunity to visit a hospital at home program where a lot of the patients were congestive heart failure patients who had gotten to a point of exacerbation. And without sending them to the hospital, the system was able to have the hospital at home intervention, get them steady again, and then discharge them from the hospital at home. So to me, that is a possibility that exists for other things. And even that model of ramping up when you need to, but having some kind of monitoring that doesn't require people to come in all the time and titrating the care model to what the need is, that has a lot of power. And yet it's not happening. But let me go back to some of the quality measurement stuff. We have a measure called transitions of care. That's when the patient is discharged from the hospital. And it's considered a poor measure because people don't have the data they need to do what the standard of care should be. In other words, have a discharge plan and take the patient through that. We know many patients go into the hospital with one set of meds, they come out with another for no apparent reason. There are all kinds of mischievous things that happen in that interaction. And this is not a measurement problem. This is a system problem. And so I wonder if you could comment on that. And I wonder how many other opportunities there are like that, where if we just made the right data available at the moment of care, we could avoid some of this stuff.
That's certainly been much of my career. I would put those things under that broad bucket of clinical decision support, which is not magic by itself. As you say, the computer and so on might be part of it, making the data available, but then having the tools, the capability, the processes that allow that to be acted on. You talked about the hospital at home for respiratory therapy as an example, but big challenge that we struggled with at a public hospital in Indianapolis was patients who needed intravenous antibiotics, but that's all they needed. So they might be getting 6 weeks for their endocarditis or something. It's really, we're going to take up a hospital bed and all of the associated costs and people for 6 weeks. You can have the information and the knowledge, but creating the process with the financial models, who's going to write the check for this monitoring? Are there enough nursing staff to go and draw the blood once a week or whatever is needed to monitor the therapy? How do you make sure that the antibiotics are delivered weekly in a refrigerated way? And so on. It's those logistics that often get in the way. And it would even a little bit of a different topic, but social needs, or I think another example of that, we can identify when patients have likely challenges with social needs. They're going to get radiation therapy for their prostate cancer. So they need transportation every day for the next 6 weeks
Yeah.
to radiation therapy, and they don't have a car and they live an hour from and we've lacked the tools in often
Yep.
cases. But I think that's exactly what we need to be driving by holding ourselves to that standard or that aspiration of patients really do need to interact and have a plan with their primary care provider within 48 hours of their discharge to reduce their need to come back to the hospital. It's hard, but we need to help the system make that happen. I think quality measurement has done that. Hospital readmissions are an example. People have learned some things. They've sorted some things out. They've made it better. So I don't think we should lower our standard or the aspirations here. But sometimes we may have to be a little bit patient on the time to get there, but making sure we're measuring the right thing and not just assuming that what we're measuring is going to be the right answer, because sometimes it allows people to teach to the test a little bit. Oh, yeah, we gave the patient a handout that had all of that information. But is that actually achieving the goal of the patient understanding the plan, having the resources to follow through on the plan? And are there things we can do to make that easier? I don't know that we ever fully realize the vision of, oh, the person needs these durable medical equipment after discharge.
Right.
Why in the world can we not connect that order at the time of discharge, make sure that all of the data gets sent to the durable medical equipment provider, whether that's Amazon or somebody else, so that equipment's on their doorstep when they get home?
Yeah. Or inside
Instead,
even.
they get home and they spend 3 days trying to arrange it and sort through the logistics. Those are all things that are possible.
A lot of this is design flaws. And I think it's been a kind of a roundabout way to go and measure failure and then let people kind of butts around, if you pardon the expression, trying to figure out how to get it better. One question I always have is there a way to encourage trailblazing? And can Medicare, as a payment program, the most powerful in the country, how can Medicare encourage trailblazing and be okay with the idea that some people are going to get much better care because of trailblazing?
It goes back to your alignment and value point, too. People may not do as much trailblazing as we would like because it's difficult for them to translate that into value for themselves, especially if they need to make an investment to go try these things. Providers and academic medical centers, where you would hope this kind of innovation would be growing, they're often the ones who, if I reduce the need for hospitalization by 50%, wait a minute, that's revenue on the other side of the coin. So, number one, that's one of the reasons that so many value based care and ACO type models have been poked at by both CMMI for Medicare and for others, because we need to create a value chain that those innovators can leverage. And it's also one of the reasons that some of these innovations, whether they come from academics or from commercial companies, are often hard to scale. You may be able to show, hey, we got a 22% improvement in something with a grant funding the work. But then how do you translate that into a sustainable model across the country? Sometimes it's specialized resources with automation and the tools that are available. That's becoming less of a barrier. Even a rural hospital often will have the capabilities technologically to incorporate some of these things and becoming more of a financial model barrier than it is a technologic barrier. The other thing that I think about is what is the philosophy of change or the eagerness for innovation? So many health systems are stressed capacity wise, dollar wise, regulatory compliance wise. They haven't established a culture of improvement and change that allows them to turn the crank every month, getting better. People talk about the learning health system. When I was a resident at what's now Eskenazi Health Hospital, every couple of weeks there would be new things happening and there would be process improvement. And you just took that in stride. It was just a constant stream of things, and we didn't think a lot about it. It was just part of, golly, this is great. Now we can do care faster, better. But today it seems like a lot of health systems, when they do these kind of things, it becomes a whole project with a marketing team and a 3-month plan and a scaled introduction. That's okay. But how do you make that part of the routine and not an exceptional event that we're improving the processes? The silver bullets in healthcare, I think, are around processes and patient engagement and things that can be leveraged across the many thousands of things that we need to do to make care better.
I don't know if it's a silver bullet, but if I lose money when I get better, then that scenario should be looked at hard.
Yes.
This alignment of incentives, it's a key. It needs to
And again, that's
unlock.
something we've ignored in healthcare.
Yeah.
Plans have a variety of value-based care models,
Right.
both upside and downside risk. Part of it is scale that makes it challenging. A lot of it is complexity of our system, though.
Yeah.
We
Yeah.
just have so many actors and so many pieces. And we are seeing consolidation in various ways, whether that's Optum owning practices, whether that's health systems that are buying up primary care and specialty practices. But that has its unintended consequences too. So it is a challenge for us to find that better alignment, but doesn't create too much friction that then get leveraged in unintended ways.
What should I have asked you that I didn't ask you today?
Maybe the question is, well, when do we expect things to be better? How quickly will things happen? I've heard it attributed to Bill Gates many times. What will happen in 7 years, we often overestimate. What will happen in 10, we underestimate. We are at that point in quality improvement where it's taking longer than we want or like, but we've set a course and there's so much potential now. So I'm excited about the next 5 years, what we will see in terms of progress in specific areas, but also progress in terms of what we're going to be able to do. Feel optimistic about where we are and the potential that we have over the next 5 to 10 years. As always, the challenge is to realize that potential and get the full value and make sure that our partners in the healthcare ecosystem, organizations like NCQA, that are focused on quality improvement, providers, payers, federal regulators, the federal government as one of the largest payers, building that. And again, that's what I think NCQA has done historically, building that coalition of the willing. And I didn't mention employers, but I think their role may come back as an even larger, given how many are self-insured and are bearing the costs directly. So I'm excited about the potential for building quality into the process, creating a reproducible way to move not just 5 or 10 obvious areas for improvement, but in the 2,000 opportunities that are out there.
Well, that seems like a good note to end on. I just want to thank you for all your thoughtful comments. That it's always drawing on your experience in such a direct way that makes this stuff come alive. So thank you very much.
Well, I appreciate the chance to chat, and I appreciate all of the work that NCQA over the decades and over the coming decades will do to make
Yeah.
quality better for all of us.
Thank you. Thanks again to Dr. Marc Overhage for joining us today. I've known Marc for years, and what I've always appreciated is how he brings both vision and practicality to his work. He helps us get excited about what's possible in healthcare and then reminds us how we actually get there. Today's conversation touched on some of the most persistent challenges in our system: fragmentation, misaligned incentives, and the limits of quality measurement. But Marc also reminded us that these aren't unsolvable problems. They're design problems, and design problems can be fixed. We talked about how clinical decision support, when done right, can help build quality into care, not just measure it after the fact. We explored how generative AI might help us make sense of complex data, and how trailblazing models like Hospital at Home show us what's possible when we rethink care delivery. We explored how AI might help us make sense of complex data, and how trailblazing models like Hospital at Home show us what's possible when we rethink care delivery. And we came back again and again to the importance of aligning incentives so that doing the right thing for patients is also the sustainable thing for providers and systems. Marc's optimism about the next 5 to 10 years is contagious. He sees a future where we don't just improve 5 or 10 things, we improve thousands. And we do it by building quality into the process, not layering it on top. That's a future worth working toward, and I'm grateful to Marc for helping us see the path forward. Thanks for listening. We'll see you next time. Thank you for joining us this time on Quality Talks. If you enjoyed this podcast, please rate us 5 stars wherever you listen. We'll see you again next time.